Hello and welcome to the programme. Well, we're almost a week into the British version of lockdown to stop the spread of the coronavirus, and the experts and the Prime Minister are telling us things will get worse before they get better. But many questions remain about testing for the spread of the disease, about protecting health workers from it, about expanding hospitals and their ability to cope, about how exactly you can tell if you have the coronavirus. There aren't answers to all of this yet. Another question is when we will have a better idea of the impact of the disease. Well, I'm joined this morning by Jason Leitch, who's Scotland's National Clinical Director. And in fact, you may just have seen about 30 seconds ago in a government health announcement before this programme came on air. Good morning, Jason Leitch.
Morning, Gordon. Thank you for having me.
Well, look, first of all, can we talk about testing? It's been rolled out for frontline health workers in Scotland, but at what stage are we now?
We're early in that rolling out process. Testing is a slightly more complex thing than people suggest. So it's a finite capacity because of people, labs and kits. So we've got 800 a day, roughly. We can do about 800 a day. And we have to use that testing to teach us the best way of dealing with the virus. That's what we've been doing. As that number goes up, the first priority will be healthcare workers and other key workers to get them back to work.
Right. So if I were a nurse or a doctor watching this who works in a hospital, can I be expect to be tested over the next few days?
Some will be tested over the next few days. So we've started that in some parts of the country already and across the 4 UK countries. Remember, we're trying to do this as a UK-wide effort. It's very important that we try and move the whole country together, because the population interventions have to be done at a UK level. It doesn't make any sense to have too much variation across the countries, although Orkney is very different from Oxford Street in London. So gradually over the next few days and weeks, we will start to do more testing, because nobody wants the intensive care doctors and the GPs and the community pharmacists back at work more than me.
And presumably, is the plan, once you get the kit, to test health workers regularly, say once a week?
No, we wouldn't test asymptomatic or non-self-isolating people. The test we really need for that is, forgive the technicality, the antibody test, yes, rather than the antigen. The antigen test tests for the virus. Yes, no, is the virus there? The real test we need, and the whole world needs, is the antibody test. So I could take blood from you just now and I would know you had chicken pox when you were 3 years old. That's the test we need for this coronavirus. And then we would begin to see immunity gather over the population. Now, that is probably not years away, that's probably months away. Every lab in the world is working on that and a vaccine. That will be the true game changer for how we deal with this virus.
Right. Apparently in Wales, they're now testing, I don't know if it's all patients who are admitted to hospitals, whether they've got coronavirus or even are suspected of coronavirus or not, in order to check whether they have it and then keep them away from other people who do have it. Is there a plan to do that up here?
So we've been doing a version of that we think is the best use of our testing capacity and the best safety mechanism. So we've been testing 2 particular groups. Everybody with respiratory symptoms who ends up at or in hospital, and particularly those in intensive care. But we've also been testing across the population. So public health needs to know where the virus is and how well it is spreading or not, depending on the social isolation measures we've put in place. So we've been doing that. We've been testing in hospitals so that we can effectively divide our hospitals into COVID patients and non-COVID patients. That's not an exact science, of course, because people develop it later on, perhaps. But as much as possible.
But are all people who are being admitted being tested?
No, there would be no sense in testing every single admission. If you're going in with a broken leg because you fell down your stairs and you have no respiratory systems, that wouldn't help us. So we test the people who need it. And just now, we only have that antigen test to use for that process.
Now, you referred to something, I think, a moment ago, which was talked about a couple of weeks ago, but we haven't heard much of for a couple of weeks, which is the idea of sample testing in the population to get an idea about where outbreaks are occurring and so on and so forth. You seem to be suggesting that's already happened.
That is already happening. So we use that for the normal flu season. So remember, the health service and diseases are continuing all the time. We don't just have one disease in this country. So influenza, which is now coming to an end at the end of March, we test in 41 what we call sentinel practices right around the country, and all of the UK countries do exactly the same thing. And we extrapolate that number up to tell us the flu numbers for the nation. So we don't test every single influenza case. We test and then use clever data to tell us how many that is. And we've been doing that for coronavirus. And now we're moving from 41 practices who will do that to 200 practices who will do that to cover 1.2 million people. And that doesn't help us with the care of the individual, because we're doing other things for that, but it does help us with the numbers around the population. We're trying to do two things at the same time, Gordon. Treat the public, treat the individuals, those who are sick, but also understand where it is and how it's working in the population. Two different mechanisms.
Right. Is that sampling compromised by another bit of advice you're giving, which is basically just about the last thing anyone showing symptoms should do is go anywhere near a GP?
No, so everybody who ends up with severe symptoms is now being told not to phone their general practitioner. And that's an adjustment in the way we design the healthcare system. So now 111 is the port of call if you have symptoms that are deteriorating. Remember, the vast majority of people will have mild disease. They will recover in 7 days by themselves with their family in their home, fluids, rest, sit in front of the sofa. But the others who get more severe illness should phone 111, and they will be directed to one of our new COVID hubs in every health board in the country, where they will then get advice about what to do next. It's to try and take the pressure from our primary care system.
I understand that. Let's explore that more in just a second. But I'm just interested in this. So where is this sample testing being done? My point was, if people aren't going to go with symptoms, aren't going to go to their GPs, then they're not going to be taking part in the sample testing.
Well, remember, we don't have one big column just for the sampling testing. We have testing in lots of different places. One element of that is symptomatic and asymptomatic people in general practices. So that could be, I could go for my iron test to my GP this week, and if I was in one of those sentinel practices, they could test me for coronavirus. No symptoms, nothing to do with coronavirus, and they would test me so we would get population level data. At the same time, of course, the hubs and the assessment centres will be treating a higher number and testing a higher number of coronavirus patients, so that we'll know when people are actually sick, and then we can direct them. So we add all that together. The clever data people then tell us where we are on the curve and how that virus is managing over the whole country. Remember, the virus here is the same as it is in South Korea. The virus isn't any different. We're not just going to be lucky. Hope is not going to fix this. So that's why the interventions have to be so stringent with what we're doing.
Right. Can I ask you, just on that, a very practical question, which I'm sure lots of people watching this are asking themselves. You asked yesterday for people to make less use of the 111 number, and unless it got serious or symptoms deteriorated. If you or one of your loved ones that you're living with has this virus, or you suspect they have this virus, at what stage does it become serious enough where you should be calling an ambulance or should be calling 111 to make sure that they don't need to go into hospital?
I understand that's a really difficult judgment, particularly with people who are so worried. It's on every news channel 24 hours, it's in social media all the time. I really do relate to the fact that this is quite difficult. What we're saying is the basic rule for everybody is stay at home. Just stay at home to save lives. If you get a cough and or a fever, you should really self-isolate for 7 days in your house for 14. And you will, in the main, even if you're elderly, even the high-end group, the vulnerable, the elderly, the vast majority of them will recover. So just treat it as if you had the flu.
Yeah.
So take to your bed, have a Lemsip, take some paracetamol and fluids, but...
Other brands are available. This is the BBC.
Correct. Other brands. So if you get breathless, and if you feel as those symptoms are deteriorating, then 111 is there for you. I'm not suggesting don't ever phone 111. I'm suggesting we need to use it wisely, like we should use our GPs wisely and our community pharmacists. Other places you can get advice. There's a hotline, an NHS 24 hotline for those who are just worried, who haven't quite deteriorated, and that's 0800 028 2816. 0800 028 2816.
Right, okay, but I guess, again, you don't want to be inundated with people who are a bit breathless. I heard one doctor, and I don't know whether this is accurate or not, saying that, I think she said, look, the test was if you can't walk up the stairs because you're so breathless, then you probably need to go to hospital.
Well, some people live with that level of breathless every day, so it's really difficult to be individual for a population of 5 million. So people should, of course, use common sense. And if they're really worried, they should talk to their family and think about it. This virus doesn't tend to give sudden, let's say, cardiac arrest. You don't suddenly collapse from this virus. There are other illnesses, of course, that do that, and we're ready for you for that. And that's a 999 call. We will come for you. We're ready. However, if you deteriorate, your symptoms seem to be getting worse after 7 days, we want you to call us at 111. We just don't want you to call 111 if you're just a little bit worried about your cough and your fever.
Okay. Now, there's been talk of perhaps setting up extra hospitals, maybe field hospitals. There's been talk of the SECC just across the street from, or across the river rather, from where I am now, being turned into a hospital. What's the situation with that?
So the first and the most important thing is we have, astonishingly, I can't believe it when I go round and talk to my pals, we've redesigned the health service in 2 weeks. Let's be very clear. So people have said, yes, let's double intensive care capacity. Seriously, Gordon, I cannot tell you how difficult it is to double intensive care capacity in 2 weeks. And now we're asking our health boards to quadruple intensive care capacity in another 2 weeks. If you told me that a month ago, I honestly would have thought you were crazy. So the first thing to say is the most important thing we're doing is we're redesigning the way we have our existing infrastructure. That's number one. Number two is we're of course thinking in our reasonable worst case scenario, if the curve really came to accelerate really fast, what would we do if we ran out of space in that existing infrastructure? We're still planning with all our hearts and minds to bring that curve down so the existing infrastructure copes. If it doesn't, then we're also thinking about where we could do good care, high quality care in another environment. And the SEC is one of those possibilities. We have some advantages because we're a little bit behind London. And I'm in touch with the people at the Nightingale Hospital at the ExCeL. I spoke to them yesterday about what they're planning, about what their clinical model will be. And we are getting that information so we can learn in time if we require it.
You don't think there's an argument? I know the disease is more advanced in London. You don't think there's an argument for starting that process in the SEC or somewhere else right now?
So we've started in the sense that we've begun to think about what that would look like, where you could do it. We've talked to our armed forces colleagues because they are very good at that kind of fast engineering. But this would have to be an NHS facility. There aren't 400 army intensivists hanging about in Scotland with nothing to do. So it's a complex arrangement. It would have to be an NHS facility supported by infrastructure, some of which would be provided by the armed forces. And I promise you that there are conversations ongoing yesterday, today, and I'm sure this week, both with the First Minister and many of the rest of us, to think about what that would look like and when and if we would need it.
Ventilators, how many do we have? Michael Gove has just said there are 8,000 in England and they've got 8,000 on the way. How many do we have in Scotland and how many extra ones do we have on the way?
So again, trying to do it on a 4-country level. So the numbers he talks about for England are actually UK wide.
Okay.
We are in that order.
I should point out that was my interpretation. I don't think Michael Gove said they weren't UK, so I don't want to.
They are. So
right.
So that order is UK wide. You can be absolutely certain that there is very strong conversations between NHS procurement, our NHS procurement in Lark Hall, with those guys. We have enough ventilators presently on the ground for that doubling I described. Now, it's important to remember that right now, only the half of intensive care is full. There are empty intensive care beds just now, ventilated, staffed. I spoke to one of my pals at Glasgow Royal last night. They have lots of empty beds. They are standing ready. In fact, he described it as kind of waiting like a coiled spring for the wave that's coming. Okay. We have orders in for the ventilators we would need for that quadrupling. And we are as confident as we can be as the world seeks those ventilators that we will get them.
We're running out of time, but can I go through a couple of things again that are pretty important? A lot of people watching this will be worried about. The Royal College of Nursing has raised this issue of personal protective equipment in a different context. I know there have been arguments about whether hospitals are getting them. The point they're making is there are lots of district nurses who may be at risk or at risk of putting their patients at risk. There are many nurses working in care homes who, same issue, and indeed many care workers are at risk of infecting the people they're taking care of or being infected by them. Are there plans to get PPE equipment out to all those groups of people?
More than plans. There is already distribution to all of those people. It's important, though, if you'll forgive me, we need the right PPE to the right people. PPE is not one thing. I've worn the full face mask during the HIV crisis when I was a surgeon some years ago. And these full FP3 masks, they bruise your face, they hurt. You cannot wear them for a long time, and you can't see properly. They're horrible things. So we need them where you need them. We don't need them where you don't need them. But you do need levels of protective equipment. And the chief nurse and her colleagues have been working very hard late last week, over this weekend, to make sure that guidance is really, really strong for the district nurses, the care workers, the police, the fire service, and, of course, the intensive care doctors.
Okay, just a last point, and again, it's a very practical thing that a lot of people will be worrying about. And I'm not sure, to be fair, that we know the answer, that anyone knows the answer to this question, which is we know about dry cough and fever and headaches, but there is some discussion amongst the medical community, isn't there, about whether other symptoms might be coronavirus. That, for example, a lot of people who might be thinking they've just got a cold, they're snuffling and sneezing, they've got maybe they've maybe got a chesty cough or whatever. How can you tell?
You can't be sure. So I have graphs, of course, from all of the cases around the whole world. So there is research going on for the few 100,000 cases around the world. Remember, we don't have 10 million cases around the world. So we don't know fully everything we need to know about this disease yet. So the two most common and definitive symptoms are the two we're talking about. That's why we've chosen them to describe to the world, to tell people what to do. Most people do not get a blocked up nose, but a small proportion do. So you can't be absolutely certain, but those two definitive symptoms are the ones you should intervene in.
Okay, look, Jason Leitch, thanks very much for joining us this morning.